Otis Brawley, who's also presenting today, is a medical oncologist and epidemiologist. He is the Michael Bloomberg Distinguished Professor at Oncology and Public Health at Johns Hopkins University. His interests are in disparities in health outcomes and cancer screening. He's a master of the American College of Physicians, a fellow of the American Society of Clinical Oncology, a fellow of the American College of Epidemiology, and a member of the US National Academy of Medicine. My co-chair today is Stephen Woolseyn. He's a director of the Center of Medicine and Media at the Dartmouth Institute. He's the founder of Lisa Schwartz Foundation for Truth in Medicine and a general internist. Stephen has worked to improve the communication of medical evidence to physicians, journalists, policymakers, and the public to help them see through excessive fear and and hope created by exaggerated and selective reporting in medical journals, advertising, and the news. You can see his research themes here: medicine in media, the science of effective risk communication, prescription drugs, overdiagnosis, and the marketing of medicine. Myself, I'm a general practitioner with more than 10 years of clinical practice. I have a PhD in public health psychometrics, and I work as a professor in prevention, medical screening, overdiagnosis, over-medicalization, evidence-based medicine, and multi-morbidity at the Center of Research and Education in General Practice, University of Copenhagen, and at the Primary Healthcare Research Unit, Region Zealand, everything placed in Denmark. My research is focused on the balance between benefits and harms of medical prevention, diagnostic test accuracy, informed consent, and what the psychosocial consequences are for healthy people when they are over-medicalized. Our first presenter is Otis Brawley, and I will stop sharing my slides now so Otis can share his slides with you. And then after his presentation, I will have a chat with Otis. But again, please make comments and questions at the chat bot. I would really encourage people to do this. So Stephen will take care of that and interrupt us if he sees something important. The word is yours, Otis. Have you muted your mic, Otis?
Okay, sorry about that. I'm sorry about that. Can you hear me now?
We can hear you fine.
Beautiful, beautiful. Thank you. It's wonderful to be here, and I appreciate the opportunity to give this talk. I'm a professor at Johns Hopkins University. These are my disclosures. I do have a consulting agreement with Genentech on accrual of clinical trials. I wrote a book a few years ago, much of it about overdiagnosis. This talk has nothing to do with the book. My purpose is to describe the pandemic as it is affecting the United States, and to describe disparities created by the pandemic, both the pandemic itself as well as other diseases. These were the leading causes of death in the United States in the year 2019. You'll note heart disease at almost 650,000 deaths, cancer at 600,000, and accidents at 170,000. Cardiovascular disease rates have been going down as have cancer rates recently. COVID, a disease that we actually didn't even know existed in January of this year, is currently is currently the third leading cause of death in the United States this year. The United States is 4% of the world's population, and unfortunately, 23% of the world's COVID-19 deaths. Now, in very good times, the United States healthcare system is incredibly inefficient, with some people over-consuming, some people under-consuming, and evidence-based medicine lacking. And there are tremendous...
Otis,
yes.
somebody's asking if you can increase the size of your slides. Can you use the slideshow? Because they're a bit small, your slides, because they are in a mode right now where we can't see the whole slide. So if you press play or slideshow.
They're in speaker mode, if you could put it in presentation mode.
Darn, this is, let me see what I can do.
You had it when we rehearsed it?
Somehow it reversed from when I was originally, let's try this. What is it for you now?
All right, yeah, and then press slideshow, yes?
Okay, I'm sorry.
Yeah, perfect.
You ever, okay.
Please go on, please go on.
All right, I'm sorry. Now, there's significant disparities in the United States by race, socioeconomic status, as well as by geography. The movement toward health equity involves science-based prevention, effective appropriate screening, and high-quality treatment. Now, the most important question in cancer control, indeed the most important question in the care of any chronic disease or even acute diseases, is how can we provide adequate high-quality care to include preventive services to populations that so often don't receive them. Minority and underserved, that is poor populations, are most likely to go without adequate care. COVID-19 was first introduced into a number of cities in the United States in March of this year. The people who got the disease were the people who were poor and working class. They had working conditions and living conditions that did not allow for social distancing. This is also the population that most commonly has chronic diseases, and they're the least able to obtain health care. This is really the perfect storm for death in a pandemic. Having all of these problems, and healthcare systems in the specific areas were overwhelmed, and this interfered with the quality of both COVID care as well as the quality and provision of normal care in those systems. It cannot overemphasize the fact that quality of normal care was overwhelmed. And it's true that the pandemic to date disproportionately affected Blacks, Hispanics, and Native Americans. Collection of race data in the United States, by the way, has been poor. And the shutdown led to about 27 million Americans losing their jobs. Many people in many states had no form of health insurance whatsoever and had to pay out of pocket for any health care. We had tremendous declines in visits for wellness and maintenance of chronic disease. As you can see here, this is during the shutdown. And then through June of this year, we had drops in visits to many primary care physicians. It is estimated by the National Cancer Institute that the decline in treatment, not screening, but treatment, will result in about 10,000 deaths in colorectal and breast cancer by 2030. So tremendous harm. Now there's declines during this period of time in the diagnosis of a number of chronic diseases to include cancer. And this is due to lack of access to care, fear of exposure to COVID in physician offices, fear of exposure in transportation to healthcare. In screening surveys, after the shutdown that occurred in the United States, March, April, May, and into June. In screening surveys, we've returned to maintenance clinic visits, 70 to 80% of pre-COVID levels. And this is a new phenomenon, including the new phenomenon of web-based healthcare providership. And people who are not participating, of course, are the poor, socioeconomically distressed, and those who get health care in the emergency rooms and urgent care centers. And we're going to have localized health care shutdowns. As COVID pops up in certain states, we're having shutdown of healthcare again. As the US society opened, racial disparities in infection actually are decreasing, and the disease is spreading more in the rural areas of the United States. And populations, unfortunately, that are poor and still have comorbidities are still overly affected, although it's more white poor who are being overly affected. Overall, this portends to a decline in population uptake of necessary care and a rise in death rates from chronic disease over the next several years. And the disparities will increase as the populations most affected by coronavirus infection are the most vulnerable, that is, the socioeconomically deprived. Now, I'll stop at that point, and perhaps we can talk a little bit more about that, John.
Thank you, Otis. Thank you so much for a great presentation. So just to encourage people that have attended the last 5-7 minutes, we are a bit late due to some problems with the email. I would really encourage people to put comments and questions on the chat because we can't open an oral discussion. But Stephen, you have had a look at the chat during my opening and Otis' presentation, and I can see that some people have made some remarks. Do you have any questions from the audience or comments to Otis?
Yeah, so far the comments I see are are more like congratulations and stuff. So I don't see specific questions yet. Here's one. This is a question from Tomar. Do you see the same trends in Denmark, or is this unique to the United States?
We see the same trends in Denmark, where we can see that contacts are decreasing, and we can see that referrals are decreasing. We can see that the vulnerable groups are not getting the necessary care. And that was actually one of my questions to Otis, that I think most of your presentation was about areas of underdiagnosis, undertreatment, not timely diagnosing. And you said that in 2030, we can probably measure this overmortality. Is that correctly understood?
Yeah, that was an estimate that just looked at the fact that in the United States in March, April, and May, we stopped treating a lot of non-urgent diseases. For example, we delayed a lot of treatment of colorectal cancer and breast cancer, as well as there were a number of people who normally would have presented, not by screening, but presented due to symptoms, who put off going to the doctor because of fear of getting coronavirus. You literally had people who knew they had a problem and stayed at home. And in the United States, our rates of stroke, myocardial infection, and cancer diagnosis have all gone down because of this phenomenon.
So your hypothesis would be that in 10 years' time, we would be able to measure this on not diagnosing, but prognosis.
Yeah, we do believe that there are going to be some casualties. Some people are going to die because they have not gotten appropriate care. Yes, there will be less overdiagnosis because there's going to be less screening, but there's also going to be less diagnosis of people who would have benefited from that diagnosis and treatment. So far, by the way, and this is actually data from the National Cancer Institute, the CISNET studies show it's not as much early on a screening problem or a decrease in screening. It's a decrease in treatment issue.
But if I should look at my point of view as a researcher, I would really like to do some research, both on the two, not timely diagnosing or the underdiagnosing, if we should call that, but I would also like to look at the overdiagnosis. And if you say that we in 10 years could measure this on the prognosis, then we would be able both to look at the underdiagnosing consequences and the consequences of overdiagnosis.
I would agree with you, yes.
Yeah, but in 10 years, I mean, can't we do it before that?
Well, I have focused more on outcomes in terms of mortality, and especially in cancer. For cancer mortality, one is going to have to wait at least, I would say, 4 to 5 years in order to see actual data. Now, in cardiac disease, in diabetes, perhaps not as long.
Stephen, are there new questions, new comments on the chat?
Yeah, there's a couple of interesting questions about reduction in infectious diseases other than COVID due to social distancing, improved hygiene, and so on. Any thoughts about that?
Well, I'm certainly not an infectious disease expert, but I can tell you just from my general reading, there may be someone on the call from Australia, they're in winter right now, and they apparently have had a decline from their normal influenza season, and I think it's attributed to social distancing and activities that are generally designed to prevent coronavirus infection are highly effective in preventing influenza. They may be effective in preventing other infections such as pediatric rotavirus.
Other questions, Stephen?
Yeah, there's a question about the attribution of death. So the question reads, Overdiagnosis discussion group has talked about dying from COVID versus dying with COVID. Has there been work done on this in the US, given the numbers and weak data with respect to death certificates?
There's not been work done on this yet that I know of. However, this is leaked into the lay press, and there's been some political operatives that have been confusing the American public with cause of death, trying to say that if someone has diabetes and gets coronavirus and dies, their cause of death should be called diabetes and it should not be attributed to coronavirus. And as such, if you use that type of distorted definition, coronavirus deaths are really 10% of what we say they are. Basically, I think that's the wrong approach, and most people, including the Centers for Disease Control, the good scientists at the Centers for Disease Control in the United States, have spoken out against that. If someone has a comorbid disease and they get coronavirus and they die, and they would not have died had they not gotten coronavirus, it's a coronavirus death.
You want more, John?
Yes, please. Yes, please. Let the audience ask the questions.
Sure. There's a question about whether there's been, you said that you hypothesized there's been a decrease in treatment, but we don't know whether there's a reduction in low value treatment. Can you comment?
Yeah, I really don't know how to figure that out right now. I'm certain that there has been a reduction in low value treatment. I'm also certain there's been a reduction in valuable treatment. I don't know how to figure out the proportionalities.
Please continue, Stephen, if there are more comments and questions.
Sure. This one's slightly off target a little bit, but there was just a Gallup poll in the United States showing that Americans have even less trust in the federal government than in the pharmaceutical industry. So given the recent regulatory and public relations missteps at the FDA and the CDC, what can be done to regain public trust to ensure that science and not politics drive policy?
That is a very good question. It's a complicated question. It's above my pay grade to answer. I will speculate that the best thing that we can do right now in the short term is for those of us who are responsible in medicine to maintain trying to explain what's going on, irrespective of folks in government, to try to continue explaining what's going on to the people who will listen. it's my long-term view that in the United States, we have a lot of folks who have not really understood science or understood the value of the scientific method. Probably true in Europe and Asia as well. You know, we have a large number of people who speculate into certain medicines or certain alternative medicines and stuff and want to reject science, right to try legislation, that sort of thing. This is a huge, huge problem. But I think what we in medicine need to do now is the responsible people in medicine need to just tell the truth and continue consistently telling the truth and saying it as loud as possible. And the politicians, we can't stop.
Yeah, that's great. One more question is, you spoke about how the system, the healthcare system is inefficient in good times. What can we possibly do now in bad and worsening times?
I think in the long term, we in the United States, you know, the United States has the most expensive healthcare system in the world, and we do not have near close to the best outcomes. I think in the long term, we in the United States need to have not healthcare reform, but healthcare transformation, where we need to rethink how we provide healthcare, rethink how we consume healthcare. We need to educate our population as much as possible regarding health, and we need to start trying to stress prevention of disease, coronavirus, as well as cancer, as well as cardiac disease or diabetes, and try, it's a long-term process that I don't see many people in the United States ready to start.
And then there's a question about to what extent is there overdiagnosis and overtreatment in COVID?
You know, that's a really interesting question. I don't know. Perhaps my public health infectious disease friends might be able to speak about that. It's certainly, there's some very interesting aspects where there could be overdiagnosis in COVID, including, and especially overtreatment of people who actually have coronavirus. I can talk more about the pseudo treatments. We were talking earlier before we went on air. There's a study looking at 1,000 cancer patients in the United States. This may be dated now because this was done in April and May of this year. Of 1,000 cancer patients in the United States, 40% who had 1,000 cancer patients with coronavirus, 40% were taking azithromycin or hydroxychloroquine, trying to treat their coronavirus. I have no idea how they got prescriptions for those, but that's pseudo treatment. We know those things don't work.
Yeah. Then there have also been a couple of questions about some of the social and mental health consequences of COVID, you know, from social isolation, depression, suicidality, and all that.
Yes.
Any comments?
Only to say that they are serious problems and that they do exist. They are public health problems. The other thing I would add to that list is post-traumatic stress among people who have had coronavirus. There's a growing literature that some of the long-termers with coronavirus, some of the people who have coronavirus symptoms 3-4 months after the initial disease, especially have some PTSD issues. And some of the people certainly who have been hospitalized and intubated clearly have PTSD issues that are going to have to be addressed or should be addressed.
I would say thank you for now for this